So today we have our panelist, Dr. Jake Harris. He is a psychiatrist and addiction medicine specialist with the Boise VA. He's going to be giving a talk on buprenorphine basics. Jake always says this, he could talk for hours, and so we give him the full hour when he's presenting.
All right, my name is Jake Harris. Normally I introduce myself right around Eli Harris, and I never say this, but we are not related. There's a lot of Dr. Harrises in the Valley that I'm not related to. So I am an addiction medicine doctor at the Boise VA. I'm also a psychiatrist by training. I'm the program director for the UW Addiction Medicine Fellowship in Boise with Dr. Powers and Dr. Darnell. And they are graduating tomorrow, so we are very excited for that. So they'll still be around for 2 more weeks, and then we start our new year. So I will be presenting on buprenorphine today. And like Shannon said, I always say I could talk on this topic for hours and hours. Luckily, you only have to listen to me for 1 hour, and I'll try to keep it to about 45 minutes so that we can have questions. I do have the chat open so I can see it. So if you put a question in there, if I will peek at it, and if it's relevant during the discussion, I'll answer it along the way, and then we can answer questions at the end. If it's very, very important for you to bring it up in the middle of the talk, then you can jump in and say that. But I'll save some time at the end for questions. All right, so we're going to talk about the buprenorphine basics. I have no financial disclosures. I don't get paid by anyone except for the VA, and I get a little from Echo, but I don't get any payment from any pharmaceutical companies, and I avoid the Sublocade and the Brixadi and the companies like the plague, so I can continue to use their products without ever having had to say I got talked to by their pharmaceutical reps. So I have no financial disclosures. I am employed by the VA, so I do say that everything that I say here today is my information as an addiction medicine doctor and not as an employee of the federal government or the VA. So we're going to talk about, go ahead to the next slide. The learning objectives. We're going to review the pharmacology and indications for the use of buprenorphine. We're going to discuss the unique properties of buprenorphine that contribute to its efficacy and safety. And then we're going to review the different formulations. And then we're going to discuss the nuances of treating opioid use disorder with buprenorphine. So one thing that we're not going to do is go into great detail on any of these things. That would require me to have 8 hours. A lot of the things that I will talk about, though, have been spoken of in greater detail in other echoes this year and in past years. And so if you're curious more about specifics of some of these things, there's probably an echo that goes into that in greater detail. So this is going to be kind of an overview. I also want to present to physicians and social workers and counselors and pharmacists and nurses and everyone who might be on this call. And so some of it will be new information, some of it will be simple for many of you, but some of it might be new and of use to others. So it makes it fun to try and broaden out the topic to the entire audience that we have here today. So feel free to ask questions about that. You can go to the next slide. So buprenorphine as a medication has been around for a really long time, but it really came into prominence with the DATA Act of 2000. That's the Drug Addiction Treatment Act. That was passed in 2000 with the intent to use buprenorphine, but what it said was that any Schedule 3, 4, or 5 narcotic medication that got specific FDA approval could be used to treat specifically opioid use disorder. So prior to the DATA Act of 2000, the only medication that we could use to specifically treat opioid use disorder that was a narcotic is methadone. And it had to be done specifically in opioid treatment programs with all of the regulations surrounding that. And so what this law allowed for a different type of medication to be used to treat in an office-based setting, which allowed the treatment to expand across the country. And just in time, because as we know, the opioid crisis really escalated in the 2000s after all of the over-prescribing of opioids that occurred in the 90s and early 2000s. Next slide. So it was not until 2 years later that the FDA actually approved a couple of different buprenorphine products for the treatment of opioid use disorder. So like I said, buprenorphine had been around before the DATA Act, and it was around before 2002, but because it wasn't FDA approved, it couldn't be used to treat opioid use disorder. But in 2002, the FDA did approve the use of sublingual buprenorphine. There were 3 initial sublingual formulations with specific brand names. So there was the Suboxone, which is the combo product of buprenorphine plus naloxone. There was Zubsolv, which was the films of buprenorphine and naloxone combo. And then there was Subutex, which was the mono product, or it was buprenorphine alone that did not contain the naloxone. So these were the initial medications that were approved for the treatment of opioid use disorder. Physicians with an X waiver after that time had access to use an effective treatment for OUD that did not require daily OTP visits, and really allowed us to expand opioid treatment outside of major urban settings. So if you looked at the maps in the year 2000 of opioid treatment programs across the country, they were in large cities, and a lot of people would not have access to that. If you look at the maps of where opioid use disorder, the prevalence of opioid use disorder really expanded, it was far outside of these urban settings, into rural settings, into suburban settings, into all settings, really. So we needed this to expand, because we can't just put an OTP in every small town in the US. Next slide, please. So 2002 is when the medications first came out and started to be used. There's the approval of other buprenorphine formulations over the years. Probufene was the very first and only buprenorphine implant. It was actually not approved until 2016, and then it was actually discontinued in 2020. It was specifically discontinued for business reasons, not because of efficacy or side effects. It was not a high-selling medication. It required an implant that was good for 6 months into the upper arm, similar to other implantable medications. And you could only do it twice, and then you weren't allowed to use any more, because it would leave behind some scar tissue. And so it had a very narrow use of being able to be used. And then what ended up happening is the long-acting injectable formulations came out. So the company that made Probufene said, no one's going to use this. We're not going to make it anymore. We don't need it. But Sublocade, the brand name Sublocade, came out in 2017 with FDA approval. And then Brixadi came out in 2023, fairly recently, as long-acting injectable forms of buprenorphine. So those are the formulations that are FDA approved for the treatment of opioid use disorder. Now, buprenorphine does come in other formulations for the treatment of pain, and so you will see those. That includes IV buprenorphine, the transdermal patch under the brand name of Butrans, and also the buccal film. The brand name is Belbuca. So you may end up seeing those. And early on, about 10 years ago, whenever I see anyone on a transdermal patch, everyone assumed they had opioid use disorder because it said buprenorphine patch. But the truth is that you can't prescribe the Butrans patch for long-term treatment of opioid use disorder. It is only FDA approved for the treatment of pain. So we'll talk a little bit more about pain as we go along. But those are the formulations that are approved for the treatment of pain. Next slide. So the regulations have changed over the years, and we've seen actually quite a few changes to different things. The CARA Act, Comprehensive Addiction and Recovery Act of 2016, allowed nurse practitioners to obtain an X waiver and prescribe buprenorphine products. So that allowed for the expansion of buprenorphine to be prescribed by other people, and really expanded the availability of it. And then just very recently, with the Consolidated Appropriations Act of 2023, Congress eliminated the X waiver altogether. So that made it possible for anyone who has a DEA license to prescribe buprenorphine for the treatment. There are no limits or caps on the number of patients being prescribed. There's no need to write an X or anything on the prescription anymore to be able to prescribe buprenorphine for the treatment of OUD. So that's been a big change, with the intent to really get everyone comfortable with and prescribing this life-saving medication. Another interesting part of that Consolidated Appropriations Act is that they also required anyone who didn't get trained graduating from med school and residency in the recent past who hasn't done addiction training to do 8 hours of addiction related CME in order to have a DEA. So basically what they did is they got rid of the X waiver that required training, but then they said everyone who's going to prescribe opioids has to have the equivalent of an X waiver. So it was interesting the way that they made that happen. But now anyone can prescribe buprenorphine for the treatment of opioid use disorder. Other changing regulations that we may see on the horizon are they're really advocating for being able to prescribe methadone outside of OTPs with more strict regulations than on buprenorphine, but in the attempt to make methadone more readily available for people who might need that. This talk, of course, is on buprenorphine, so we're not going to go into methadone as much, but methadone is a very effective treatment for opioid use disorder as well, so that expands that. Next slide, please. So before we jump into buprenorphine itself, a quick review of if you were a pharmacist or you worked for the pharmaceutical industry as a chemist, and they said, what would the ideal drug for MOUD do? If you were designing it, you'd want basically all of these things. You'd want the drug to have a long half-life, meaning you want it to last long in the system so that you don't have ups and downs, so that you potentially can dose it just once a day or even once a week or once a month. You want the medication to last a long time. A lot of drugs don't last a long time, and if you see someone who uses, say, heroin, the half-life of heroin is incredibly short. It gets converted to methadone, but people crave the next dose of heroin so quickly that they're on this cycle of use, intoxicate, anticipate withdrawal, have withdrawal, and then crave, and then need it again. So you want the medication to have a long half-life. You want it to reduce cravings. You want it to do something to the brain that helps the brain say, oh, I don't need that other drug as much. You want it to eliminate withdrawal as well. A lot of people who are intent on quitting, they can never quit because they get to the withdrawal and it's intolerable and they have to use in order to treat that withdrawal. So you want a drug that's going to eliminate withdrawal. Ideally, you want a drug that's going to block other drug use. So you want the medication to be on board, and if they then use the other drug, they're not going to get the same effect, or they're going to get no effect at all. You want to have a low misuse potential. You don't want the medication to give them a significant high. You don't want them to get intoxicated on the medication that you're using. And then you want the medication to have a good safety profile. You don't want it to cause liver problems, or you don't want it to have such a narrow therapeutic window that people can accidentally overdose on the medication that you're giving them. You don't want them to have respiratory depression with it. And then you may want it to have a deterrent for misuse. You want to make sure that they're not going to be selling that medication or using it the wrong way. So these are some of the things that would belong to the ideal drug for the treatment of opioid use disorder. Next slide. So when it comes to buprenorphine and its unique pharmacology, we get all of these things. So buprenorphine is really one of the medications that fits the intent of its use incredibly well. Buprenorphine has a long half-life, 24 to 36 hours. I at one point had read up to 51 hours, but it's got a long half-life. We'll talk later about how you still may be dosing it multiple times a day despite this long half-life. But with that long half-life, what you know is that between doses, you don't get as significant withdrawal. You don't have the ups and downs. And in many cases, in many patients, you can dose it once a day, and that can be enough. So they don't have to dose over and over and over. You want a medication that reduces cravings. The partial agonist effect of buprenorphine does this. So buprenorphine is an opioid medication. It activates the opioid receptor and creates an opioid effect. And by doing that, it reduces the cravings for other opioids. Because it's only a partial agonist effect, it doesn't have a really strong effect compared to some of the other opioids that are used, and therefore reduces, I'll talk about that in a second, reduces misuse potential, but it will alleviate cravings. It eliminates withdrawal because it is an opioid that when somebody goes into withdrawal, the buprenorphine activates the receptor and keeps that withdrawal from happening. It blocks other drug use. So I'll talk about affinity in the next slide, but it has a high affinity for the receptor, meaning it really can seek out that receptor and find that receptor really well, higher than other medications. And then a slow dissociation, meaning it falls off of the receptor more slowly. And what that means is that if you get all of the receptors occupied by buprenorphine, there's no room for other drugs to come in and occupy that receptor, and the buprenorphine doesn't let go as readily. And so when somebody does use another drug, they either the effect is severely blunted or they don't feel it at all. Because of the partial agonist effect, there's lower misuse potential with buprenorphine. The euphoria from buprenorphine is nowhere near the euphoria from other drugs like heroin or fentanyl, or even oxycodone, and the high that people can get from it. Now, someone can get high on buprenorphine, and I've certainly seen patients who do that, but the patient who is used to the high of fentanyl, to the high of heroin, they won't trade that for the high that they could potentially get from buprenorphine because it's just not there. So that makes it a much lower potential for misusing it, intentionally going higher and higher on the dose. People just don't do that as nearly as much as they would with other drugs. It has a good safety profile. Because it's a partial agonist, it has a ceiling effect. And the ceiling effect is really pronounced with respiratory depression, to where the effect on breathing that you see goes higher and higher with other full mu agonist opioids, and leads to respiratory suppression and can actually kill people because they stop breathing. The buprenorphine is significantly lower risk of having that happen. And so it's a lot safer to use. It's a lot safer to use in overdose of buprenorphine. It's a lot safer to use in long-term treatment. And it's safer than other opioids when combined with other things like alcohol or benzos. Not that it's doesn't have some risk, but it's safer than other opioids in that case. And then the deterrent for misuse is the addition of naloxone. So not all of the products, it does come in the mono product without that addition of naloxone, but naloxone was added specifically with the intention of making it so that you cannot take a buprenorphine naloxone tablet or film and inject it. So you can't just dissolve it and then inject it to get high, because then the naloxone is active. If you crush it and you snort it, the naloxone will be more active in that sense as well than it would have been had you taken it the right way, which is underneath the tongue. The naloxone, when you take it, this is a common misconception. When taken appropriately, the naloxone dose is low enough and there is almost no absorption. There is some GI absorption of naloxone, so some of it does get into the system, but it's such a small amount and it has such an incredibly low half-life, a short half-life compared to buprenorphine, that it's essentially negligible. So when somebody says, oh, I don't want the product with naloxone in it, it will make me go into withdrawal, that's not the case. The naloxone is not going to cause withdrawal. It's not going to really be physiologically active in patients if they're taking it the right way. And so it's really only added in there as a deterrent for misuse. That doesn't mean that you have to always use it. There are good moments to use the mono product. There are appropriate uses of that. But overall, we do recommend starting with the combo product just to have that there, because most people don't notice, and there's no side effects from the naloxone component. Okay, next slide. Okay, I put this in so we could talk a little bit about affinity. Affinity, I think, is a little bit confusing for some people. The way that that I describe affinity is how much out of the total amount of buprenorphine is going to be attaching to or attracted to the opioid receptors. So the higher affinity, the more likely an individual molecule will be attached. So I put in this slide a table that has affinities. Because pharmacists are brilliant mathematicians, they like to use numbers that seem opposite to everyone else in the world. So the higher the number here, the Ki, the actually lower the affinity is. So we've got at the top left there tramadol with this really high number. And what that means is that tramadol has a very low affinity. It's not very attracted to the receptor. And on the other end on this slide, you have sufentanil, which has an incredibly low affinity. So on this slide, if you look, the next highest affinity is buprenorphine. After that is a hydromorphone or dilaudid. As you go down, fentanyl is a little lower on the list on this graph. Fentanyl is interesting because it has a really wide variability because of different genetic variations in the mu-opioid receptor. So in some people, fentanyl has a much higher affinity that's closer up to hydromorphone and buprenorphine, and in some people it's less. So in this table, they put it lower down on the list. But so the higher the affinity, the more likely it is to attach to the receptor and therefore be able to outcompete any of the other drugs on it. So if you think of in the brain, if there are 100 opioid receptors available and there are 100 buprenorphine molecules there, then because it has such a high affinity, and this number is made up, but to prove the point, but of those 100 buprenorphines, 99 of them might be attached at any given time to those 100 receptors. And then only one of them would be open. Where the opposite of tramadol, if you have 100 tramadol sitting there and 100 receptors, there might be only one of those tramadols attached at any given time. And so there are 99 other opioid receptors available. So that is a good kind of explanation of what affinity is. And because buprenorphine has such a high affinity, it attaches to all of the receptors, and then other drugs can't attach to it. It also has what we call a slow dissociation, which means that once it's on the receptor, it doesn't fall off as easily or as quickly as some of the other drugs. So that means it's on there longer and is blocking it longer. In reality, what is happening is the molecules are moving around rapidly and bouncing off of things and attaching and falling off, and then another thing can attach and fall off. It's a very dynamic process. So it's not like it sits on the receptor for several hours at a time and then keeps anything else from getting onto that receptor. But in reality, what happens is one buprenorphine will be attached, it'll fall off, another buprenorphine will come in and take its place and fall off, and over and over and over again. So the more buprenorphine you have in there, the more it's blocking other drugs. That's basically the explanation of affinity. That can be confusing. I'm happy to answer questions about it, but for now, let's go to the next slide. All right, so the pharmacology of buprenorphine, it's a semi-synthetic analog of thebaine. So thebaine is a naturally occurring substance that is also used to make oxycodone, OxyContin, naltrexone. And then it gets chemically altered enough that we call it a semi-synthetic analog. So it's metabolized in the liver and then also has a less active metabolite, norbuprenorphine, which you can check in urine. And because of extensive first-pass metabolism, what that means is everything absorbed in our gut goes through the liver before it goes to the rest of the body. And so the liver gets the chance to take out all toxins as much as it can before things that we eat get into our system. Buprenorphine is caught pretty quickly by the liver, and that's what we call first-pass metabolism. So it's the first time it goes through the liver, it gets metabolized pretty readily. So any buprenorphine that gets absorbed in the GI tract is likely to get wiped out by the liver, metabolized by the liver, but also the GI tract doesn't absorb buprenorphine very well. So if you swallow buprenorphine, then you have less than 5% of what you swallowed is actually going to get into your system and be used. So the sublingual or underneath the tongue administration bypasses that first pass metabolism. What that means is that the veins that take blood from the mouth go directly back to the heart and don't go through the liver like the blood supply from the gut. And so it allows bioavailability, meaning the amount of the buprenorphine that is in the pill or film compared to the amount that actually gets absorbed and used, to be right around 30%. So, which is also not great and can have some variability, which is not great. That's the one downside of buprenorphine treatment, but it's a lot better than orally. So all of the formulations have to bypass the GI tract if they're going to be effective. So we have sublingual, we have transdermal or across the skin, and then we have injectable formulation. Next slide, please. So then we have the long-acting injectables that I had mentioned. There's two formulations of long-acting injectable, Sublocade and Brixadi. Both of them form a depot, basically a formulation that slowly dissolves and releases the drug in the subcutaneous tissue. That both last well over a month in their monthly form and slowly dissolve that way and release the drug. So Sublocade came out first and has been used for about 8 years now. Brixadi just came out within the last 2 years. Sublocade is given in 300 milligram dose or 100 milligram doses, and those are the only doses that they come in. I have spoken about Sublocade in Echo, I think maybe 2 years ago, and really went into some more of the details of it, but I'm going to skip over a lot of those here unless people have questions about it, but it has been discussed in Echo before. And then the Brixadi, which is a newer one, can be given in either weekly formulations or monthly formulations, which is pretty cool. It gives us more opportunities to adjust the dose for what people need. And then the weekly dose ranges from 8 to 32 milligrams, and then the monthly dose ranges from 64 to 128. So real quick with the Sublocade, the normal standard way of doing Sublocade is that you give, for the first 2 months, you give 300 milligrams, and that loads them, that gets the levels to be quite a bit higher. And then when the levels are up to where you want them to be, then you can drop down to 100 milligrams. From there, that's kind of the original standard dose of that. What we've learned, though, is that because of the initial slow absorption of it, that often requires overlap of oral medications, there are starting to be newer protocols where you can give the second dose earlier, and you can also give 300 for an extended period of time. So in cases of patients that really have severe cravings, especially in the era of fentanyl, a lot of patients will be on 300 milligrams every month long term. So that's one thing you can do with that. Brixadi has the slightly lower doses with 128 milligrams that tends to kick in a little bit faster. And so you don't have to give a loading dose with the Brixadi. Next slide. So I've included a picture found on the internet, so of where you can see he's got 2 lumps of Sublocade injections in his belly there. That's kind of what it looks like. It feels almost like there's like a broken crayon under the skin in its hardness and the shape of it. And the most common site is to give it around the umbilicus, around the belly button, so you can rotate those sites. You can now give the Brixadi and the Sublocade in the other locations in the body, including the legs and the arms, but the abdomen is still the most common site for that. Next slide. So why would you want to use a long-acting injectable instead of the oral sublingual dosing of it? One, poor adherence. If they're just not, somebody lost volume. Can more people hear me? Okay, all right. So I'll let somebody else deal with that. I just saw that in the chat. Poor adherence is one reason that you would go to long-acting injectables. So somebody can't consistently take the sublingual and then they go off of it because they forget to keep using it, and then they end up using other drugs. You know, the very first patient I ever put on the long-acting injectable had comorbid meth use, and he would use the buprenorphine consistently and stay away from heroin until he would relapse on meth, when he would return to using meth. And then 3 or 4 days into his meth binging, he would realize he hadn't been taking his sublingual Suboxone. So he would then start using heroin, and then he would go back and get on the Suboxone later. We put him on the Sublocade so that wouldn't happen. And not only did he not use heroin when he would use meth, it actually decreased how often he ended up using meth as well, because he had the shot on board and was unable to stop taking it. So poor adherence is a great reason. They could forget to take doses, or they could intentionally not take the doses. Sometimes it might be because they can't safely store their tablets. So someone who's homeless might say, oh, can you just give me the shot? Then I don't have to keep track of my pill bottle. It's been stolen 10 times already. Some people with children in the home are not, they don't want to be on a pill that their children could take. There are other solutions. They could get a safe, but that could be a reason that somebody would want to be on the shot. It may be just a burden of taking the oral medication. Some people don't want to be on, have to remind themselves to take a medication every day, so the shot can help. Others, it could just be a patient preference. In some cases, it could be the concern for diversion. So if there's a worry that they are trading their buprenorphine for other drugs or for money, then they wouldn't be able to do that with the shot. And then in some cases, the courts order it because they don't want them to have access to pills. That's my least favorite reason, but it can be a reason. So next slide. All right, so back to what we use buprenorphine for, and I kind of want to review what we used to initially use it for, and then kind of how that has morphed and changed over the years. So in the early 2000s, when we first started using buprenorphine, everyone did it kind of the same way. Everyone was worried about it. A lot of people treated it as almost like it was an OTP, an opioid treatment program, where methadone is given, and there was a lot of reticence to prescribe. There was a lot of reticence to give any freedom to the patients on things, and that really has changed. But the standard induction protocol for starting someone on buprenorphine for a short-acting opioid like heroin or oxycodone or many others basically involves dosing buprenorphine usually at 2 milligrams or 4 milligrams several hours after the last dose of their opioid, when they're already in mild to moderate or even severe withdrawal, and then monitoring for effect and monitoring for symptoms of withdrawal, and then slowly titrating that over days to weeks to a dose range of 8 to 24 milligrams. So there are definitely times of still using the standard induction that we would use. But interestingly, initially, the recommendations were to always start it in office and have patients start their buprenorphine while they're in your office. Over time, we've realized that's really not necessary. And doing an in-office induction, I haven't done one in 10 years. It's just not necessary. Especially, the worry would be, what if you precipitate withdrawal, or what if they don't tolerate it? So you can mitigate all of those things by letting them know what might happen. And really, honestly, if I'm going to precipitate withdrawal by giving someone buprenorphine, they would probably rather be at home if I'm going to give them diarrhea from their medication, and not in my office or lobby of my office. And so even if they have that mild withdrawal, you can treat it, you can talk to them about that and do a home induction. So home inductions are very safe. Other things that we really did in the beginning that we've kind of changed over the years would be, we required much more frequent visits, maybe next day or within 2 or 3 days, and then every week for several months before we allow them to go to monthly. There would be strict and frequent urine drug screenings, so people would get urine drug screens the next day and then the next week, and on every single visit to make sure that they weren't using. And then they'd be very strict about it. And so I remember people being strict early on about, oh, if it has cannabis, then I won't prescribe Suboxone, buprenorphine to somebody. And that's changed a lot. There was a lot of mandatory concurrent psychotherapy. Psychotherapy is a requirement to be available to patients on opioid use disorder treatment, but it is absolutely not required. And the kind of progression we used to call MAT, we used to call buprenorphine part of MAT, medication assisted treatment. Then we changed it to medication for addiction treatment, and now we call it medication for opioid use disorder because it's the primary treatment. You do not need other treatments. It does not need to be an assist to it, something else. It does not need to be an adjunct. It is the primary treatment for opioid use disorder. So you do not need to require psychotherapy. Many patients won't need it. And then, a lot of early on, we would withhold medications for missed appointments or positive urine drug screens. And that's really changed to focus on the harm reduction of that and to make sure that we don't interrupt treatment with their buprenorphine. So now guidelines say for example, treat different substance use disorders as independent substance use disorders. So if somebody has alcohol use disorder and opioid use disorder, and you're treating them for opioid use disorder with buprenorphine, treat that separately than you treat the alcohol. Yes, it is risky, or more risk than not, to drink while on buprenorphine. So there's that risk that's there. And what we used to say is, if you keep drinking, then we can't give you any of the buprenorphine. But if you look at it from a bigger picture, if you stop their buprenorphine and they go back to using heroin or fentanyl and they're still drinking, that's a bigger risk. So treat the different substance use disorders separately, and ongoing use of a different substance should not automatically say that you should stop giving them buprenorphine, regardless of what that substance is. There's definitely ones that are riskier, but you need to be cautious in doing that. And that's not an automatic done, you can't get buprenorphine anymore. Continued use of other opioids is not an automatic no more. It often means that they need more help, but it doesn't mean that they need to be off of their buprenorphine. So if they're still positive for fentanyl 3 weeks in, then it doesn't mean buprenorphine's failed. It means that you might need to go up on the dose. You might need to get them into other treatment options. That may be where a residential program or an IOP is going to be helpful in this case. But you don't stop the buprenorphine just because they have positive urine drug screens. So we've really learned a lot about buprenorphine treatment, that we don't have to be as strict. And a lot of this is due to the fact that of the pharmacological properties of the buprenorphine. The safety profile of the buprenorphine, the fact that people don't really get great highs compared to other opioids from it. And so if they are the kind of thought of like, well, my patient's just misusing this as well, that's actually not very common for them to misuse it to get high. They're much more likely to misuse fentanyl and get a really good high if you stop giving them buprenorphine. So we've really expanded our flexibility with that, and very appropriately so. Next slide. Another thing that we've learned along the way is that higher dosing is usually better. A lot of studies initially used lower doses of the buprenorphine and showed that it wasn't very effective. In fact, when they compared it to methadone in early studies, methadone was superior to buprenorphine, but they were using low doses, 2 to 8 milligrams, not the higher doses. What we know now, especially in the era of fentanyl use, is that the higher doses are often needed. So this chart I stole from a presentation at ASAM given by Mark Greenwald, one of the original scientists who researched buprenorphine. And it basically shows on the very left, there's obvious underdosing of buprenorphine that can happen when somebody's craving and they're in withdrawal and they're telling you it's just not enough and they're going to go use fentanyl or heroin. Like, that's very obvious underdosing. Then you get into the less obvious underdosing, where maybe you've gotten rid of their significant cravings in your office. So in your office or in the residential program, they're able to say, yeah, I'm not craving right now, it's fine. And I'm not withdrawing, so it's fine. So it looks like an appropriate dose in that setting, but it actually is likely to be underdosing. If you've got them down around 8 milligrams, 12 milligrams, sometimes even 16 milligrams, it can be underdosing that's not very obvious. And why is that? Because it often takes higher doses to block opioid liking. So even if they aren't having cravings, if they go out and they use fentanyl and they're on a lower dose, they're still going to like it. And their brain's going to say, oh, you can do both. Look, you're on buprenorphine, but you can still use fentanyl. whenever you want. And then the buprenorphine will keep you from going into withdrawal. That's fantastic, but I can use fentanyl on the weekends. Great. Now I can do both. So you might need higher doses to block that opioid liking effect. You might need higher doses to block that opioid seeking effect. Their brain is still might be saying, I'm not really craving, but it's still going to be telling them, go get something, go get something. With every little blip, every little stressor, they're going to be like, oh gosh, I want to use. So you really want to block that opioid seeking. And then you want to block the respiratory depression, and that'll happen at those higher doses. So if you have someone on a low dose of buprenorphine, they're much more likely to overdose on fentanyl if they're using it, because it will just flood out the buprenorphine. So the higher doses are really necessary. So we really have learned that higher dosing is usually better. The traditional 8 to 24 is probably not right, and we should be looking at 16 to even up to 32, sometimes maybe even higher in specific cases than 32 milligrams when we're treating fentanyl. Next slide. I mentioned that I would bring this back up. We used to dose just daily. We'd want to just give all 24 milligrams in the morning time. And what we've learned over time is that patients often don't do well with just daily dosing, and we have to dose multiple times a day. First, if you're treating pain, if you're treating comorbid pain with it, you probably need to go multiple times a day, because the pain effect doesn't last that long. But even if there's not a component of pain, this is from the same presentation from ASAM, the big blue line, that shows once a day dosing, and that big red line, the thick with a T, shows the lowest level of, at once buprenorphine levels reach that level, then patients start to feel withdrawal symptoms. And so you can see, even at 24 milligrams, giving it just once a day, what ends up happening is most of the day they're below that threshold of withdrawal symptoms. And so they're going to potentially want more. Now, the green one shows 3 times a day. It still dips below that mark, but it dips below it for less time. So they're less likely to be in that period of withdrawal, and therefore less likely to go using that. So we have learned also that you might need to dose buprenorphine multiple times a day, and that's okay. Next slide. Treatment of pain. I think we're getting close so that I can open up for questions, but buprenorphine is incredibly effective for the treatment of pain. A lot of guidelines are starting to say chronic pain, you can use buprenorphine. That's not the purpose of this talk, so I'm going to touch on it briefly, but we know that it can treat comorbid pain when there's opioid use disorder, but we also know that independent of opioid use disorder, it is a safer than full mu agonist medication that can be considered for the treatment of chronic pain. That doesn't mean we have to, and that doesn't mean that we should just start putting everyone on buprenorphine now for pain because it's safer than the other opioids. We should still avoid starting opioids on people. We should still avoid letting short-term opioids become chronic opioids in people. So I don't want to say go out and use buprenorphine because it's incredibly safe and better just for the treatment of pain. But it is safer than other opioids and is a good treatment option. And that's all I'll say about that. Perioperative management of pain in patients on OUD, that's changed. We used to say people had to get off their Suboxone for several days and then get the surgery and then do full agonists after the surgery, and then we have to do a reinduction at the end, and it left a lot of room for withdrawal and terribly treated pain and return to use because they were in withdrawal. And what we've learned over time is that you don't need to stop the opioids, the buprenorphine. You can give full agonist opioids on top of it. You can still get adequate pain relief with actually mitigated euphoria and mitigated respiratory depression if you just stay on the buprenorphine. This is a slide also from Greenwald data that shows an analgesic sweet spot. So if you need to, what that means is that if you do need to reduce the buprenorphine dose down to between 8 and 16 milligrams, then there's enough receptors open for full mu agonists to work really well on their pain. Oftentimes you don't even need to reduce it at all to get that dose. So there are other talks on pain in the treatment, and you know, we could talk for an hour on this, but I'm going to go to the next slide. Fentanyl kind of changed a lot. Changed the way we treat opioid use disorder, changed our dosing, changed the way we do inductions. Fentanyl and its analogs, which are high potency synthetic opioids, they've overtaken heroin and prescription opioids. You almost don't see, I've seen heroin once in the last 5 years. It's the most common thing that we're going to see. People that say that they're using other opioids that they're buying on the street, it's probably fentanyl. Fentanyl's in everything. We really have to be careful. The use of fentanyl is so much higher than the prescribed doses, and that's problematic because it's a very lipophilic, highly lipophilic, meaning it's attracted to the fat cells. It gets deposited in our adipose tissue and stays in there for a really long time, especially with these high doses. So you get this really long tail end that makes starting buprenorphine using the standard induction really difficult, and you can precipitate withdrawal. So it's kind of changed the way we do that. Next slide. I'll answer your question, Lori Price, here in a second. Low dose inductions came along and said, oh, we could do that. If you started really low and they continue to use the fentanyl, then they never feel it and you can go up. So low dose inductions became popular, but the biggest problem is they kind of got to keep using fentanyl. So you're telling your patients keep going out there and using fentanyl while we do this low dose induction. So you start at really low doses with that. And often it involves using non-off-label medications, which is technically not allowed, like the Butrans patch or the buccal films or the IV, to get to really low doses. None of those are within the Data Act, so they're not technically legal to use for treatment of opioid use disorder. I don't know that anyone's gotten in trouble for that or would, but that's one of the other problems. And then the titration of the buprenorphine is done over several days, 2 to 7, maybe even up to a week, 2 weeks, 3 weeks can be done. There's a big concern for ongoing fentanyl use that limits these low-dose inductions. You can use low-dose inductions for methadone to convert from methadone over to buprenorphine in a controlled environment. Let's jump to the next slide because it's my last slide and it's my second to last, we gotta go. High-dose inductions have since come out where they involve, as you mentioned, giving them really high doses, 16 and accelerated doses for withdrawal symptoms. And you usually want to start 6 hours at least after their last fentanyl use, but can be done 36 to 48 hours depending on that person's withdrawal. So some people, if they're like, oh yeah, I can have no withdrawal for 2 days, then wait those 2 days to start it if they're comfortable waiting that long because you're just less likely to have problems. But if they start at 6 hours and they're craving at that point and they really need to use, then you can do it at that point. You don't have to make sure they're not still using fentanyl to do the high dose. So if they go out and use fentanyl later that day, even though you started the Suboxone or the buprenorphine that day, you still want to dose them again the next day. Abstinence, of course, is the goal. And then it's a good way to use it after if someone's been given naloxone in the field or in the ER for an overdose. Then if you give them the high dose induction after that, you will actually relieve a lot of their withdrawal symptoms. And what we're finding is precipitated withdrawals is happening a lot less in these cases than we expected that it would happen. But if it does happen, you can still use adjunctive withdrawal meds. There are other talks on high dose induction, so I'm going to skip through to the next one and then be available for a minute or two. Kratom use, we see a lot of kratom use here in Idaho because it's legal. It has an effect on the opioid receptor and therefore can be treated like an opioid use disorder. Some people like the term kratom use disorder. It's not technically in the DSM, so it's not really a technical term. But depending on the dose of the kratom and the formulation they're using, if they're using 7-hydroxymetragenine, is much stronger, then it has a high opioid effect, just like other opioids. And so usually the standard induction can be done and effective for patients on kratom. Sometimes patients on kratom will stabilize at lower doses of buprenorphine, but be prepared to go to the higher doses with that. But don't be afraid to use buprenorphine in patients who use kratom. And there are talks on kratom out there. One was recently done. So with that, now we only have 2 minutes for questions. So I'm going to zip it and go to questions.
I think you kind of already answered Lori's question in the chat there, Jake, but anything else you want to touch on with that?
No, there are many different protocols, and that's one of them. And yeah, I don't have time to go into the different ones, but yes, it can be done, and you can give much higher doses safely and effectively.
Great. Any burning questions for Jake? All right. Well, it was a nice, thorough presentation then.